webinar. So thank you everybody for joining. I think now this is the fifth webinar in our series with Oxford and UM6SS. So today's presentation is on health workforce in Morocco, what works for whom and under what conditions. And we have a few speakers today. We'll start with Professor Jaafar Heikel, and then Dr. Asbayu Malika and Jabreen Diallo. Dr. Asbayu will present on determinants of individual performance, and Jabreen Diallo on relist evaluation on what works for whom and under what conditions. And then we'll have some time for questions and discussion at the end. If you have any questions, please feel free to put them in the chat as we go along, and we'll have time for them at the end. As with the past webinars, this one we will be recording as well. So thank you very much, and I will pass it over to our Morocco colleagues to get started.
So thank you. I'll start from this slide to see how actually challenges facing human resources for health in Morocco shape their outcomes in terms of performance and then in terms of quality of care, which is our ultimate outcome that we are trying to influence through this research. So if we draw back on the insights by Professor Zakaria last time, we can say that the challenges facing human resources for health in Morocco can be seen as a chain of interconnected issues, starting at the organizational level, as you can see here. So insufficient training, workplace shortages, and imbalanced distribution, alongside weaknesses in management and organization, create difficult working conditions, especially high workloads, like you can see over here, and then low job satisfaction. These conditions then translate into individual consequences or outcomes, with high level of stress, burnout, and then reduced capacity to cope with pressure, affecting then the overall well-being. So in simple terms, the individual difficulties observed among healthcare workers are largely driven by structural and then organizational problems within the system. So that's why we try to capture through this IPO healthcare framework what is going on. So in terms of input, this includes staff, resources, and organizational contexts. And then these are transformed through processes like recruitment, training, and work organization, which influence stress and motivation. The resulting outputs affect performance and ultimately determine the quality of care. Several researchers have examined these dynamics in Morocco, like you can see here below. Here are examples of the work done by Professor Zakaria and even other researchers in the Moroccan context. But to the best of our knowledge, few studies have addressed outcomes in terms of work-related stress, especially regarding how it affects job performance and the quality of care. That's why today, where our first objective will be analyzing how job stress affects the individual work performance in healthcare setting. So before doing so, we have to define job stress, which refers to a psychological state that occurs when an individual perceives that work demands exceed their coping resources and threaten their well-being. Then, when it comes to individual work performance, it refers to the degree to which an employee effectively fulfills job tasks and contributes to your organizational goals through their behaviors and outcomes at work. We adopted the Koopmans and all model that divides this construct of individual performance in three components, which are task, contextual performance, and then the counterproductive work behaviors. So for task performance, it refers to the effectiveness with which an employee performs core job duties that contribute directly to the organization's technical and operational goals. And then contextual performance refers to the voluntary behavior behaviors that support the organizational environment, such as cooperation, helping others, and demonstrating commitment beyond formal job requirements. And then for counterproductive work behaviors, they refer to the intentional actions that harm the organization or its members, such as absenteeism, negligence, or interpersonal conflicts. So our research focus will be on examining this relationship in the healthcare settings, as I said before. Our research methodology approach is structured around 3 main steps. First, we conducted a literature review to identify the key concepts and formulate hypotheses about the relationship between them. Then we refine these hypotheses through an exploratory qualitative study, and then we test them empirically using a structural equation modeling with the SPS PLS software. So about our literature review, there has been a long-standing debate about the relationship between job stress and performance. If you can see through literature, you can see that some studies suggest that there is a positive effect of stress on performance. Others see that it's negative. Some propose a U-inverted theory, and then others see that there is no relationship at all between them. However, more recent empirical research tends to show that the relationship is mostly negative. These inconsistencies can often be explained by the lack of consideration of moderating variables and differences in research methods. So to address this, our literature review focused on the negative perspective and aimed to identify the main moderators highlighted in prior studies, as shown in this table. And then among them, social support emerged as the most prior factor, with 5 studies mentioning it as a key moderating factor. So we adopted this theoretical model, and then we further support our choices by conducting a qualitative study, as we said before, to verify if these are the same outcomes that we have in the Moroccan setting. So we conducted our qualitative study using some structured interviews with 20 healthcare workers. The thematic contact analysis showed that the relationship between stress and performance tends to be negative. So that confirms what we already highlighted through our literature review. And then social support appears as a key factor for 19 out of 20 participants. So that's why we said that we maintained our moderating factor of social support and divided it into social support from a supervisor and then from colleagues. And then we try to account for the controlling variables like gender and then the age and seniority tenure in the workplace. And then we will present our third study, which is about the questionnaire-based approach. And then this study uses a quantitative questionnaire-based approach, like I said. After developing and pretesting the instruments, the data were cleaned and validated using SPSS. And then finally, causal relationships were tested through structural equation modeling with smart PLS, like you can see, as you can see here. The findings show that work stress decreases performance and increases counterproductive behaviors. As for social support, supervisor support improves performance but doesn't affect counterproductive behaviors, and coworker support doesn't show any real effects. Emotional intelligence, however, improves performance and reduces counterproductive behaviors. Excuse me, I forgot to say that here emotional intelligence emerged from our qualitative study. There are many healthcare workers that say that emotional intelligence is a key determinant or moderator for the stress performance relationship that we are trying to test through here. So that's from where we get this emotional intelligence as a key factor. Next. And then for moderating effects, supervisor support helps strengthen task and contextual performance, but it affects on its effects, on counterproductive behaviors goes in the opposite direction than expected. Co-worker support doesn't play a moderating role, and finally, emotional intelligence doesn't show any moderating effect despite its direct impact on performance. So we try to discuss this through literature to see how these findings can be explained. So job stress kind of drains people mental and emotional energy, so they become less efficient and more likely to show counterproductive behaviors. Supervisor support usually helps. It can motivate people, make things clearer, and create a sense of security. But sometimes, if it becomes intrusive and feels like pressure or too much control, it can actually add to the stress. Then, for coworker support, the lack of effect makes sense because not all relationships at work are the same. It really depends on trust, closeness, or intimacy we have with people, and then the type of support. So it's not always helpful. And then emotional intelligence clearly helps people perform better and avoid negative behaviors because they manage their emotions and interactions more effectively. But on its own, it's not enough to protect against stress if people don't have the right resources to cope. And now let me share with you our further research directions on the subject. We will try then, it will be interesting to look at other factors that could influence healthcare professionals and well-being, like organizational culture, leadership style, or how workload is managed. It would also be useful to explore the role of psychological resources, things like resilience, sense of meaning at work, or psychological safety, and how they impact both well-being and quality of care. And then another important direction is to better understand team dynamics and collaboration between professionals, as presented earlier by Professor Zakaria, and how these shape both the work environment and patient outcomes. Finally, future studies could focus on institutional factors such as staffing levels, autonomy, work organization, or even digitalization, to see how they affect the link between well-being and work and quality of care provided.
Professor Jaafar Heikel is our new Director of Strategy and International Relationship at the Mohammed VI Foundation of Health and Sciences. He's also the General Executive Director of the African Academy of Health Science at the Mohammed VI Foundation of Sciences and Health in Morocco. So please, Professor Heikel, could you join us and activate your mic and share with us the strategy of the Mohammed VI Foundation of Health and Science in terms of capacity building of health workers and so on. Please, the floor is yours, Professor Jaafar.
Hello, good morning, everyone. I don't know if you can hear me. Is it okay?
Yes.
Okay. First of all, I would like to thank my colleague and friend Professor Balghiti for the tremendous work he's achieving, not only at the International School of Public Health, but at the Mohammed VI Foundation for Health, for Sciences and Health. Thank you so much, dear colleague. Thank you so much also for Oxford to be with us and to share with us the experience. And thank you for everyone being present today, all the participants to share their knowledge, their experience. If I may, I would like to share with you some experience concerning the human capital, or if you can say human resources, not only at the level of the Moroccan context, but also thinking about the African context and taking into account what have been achieved at the Foundation Mohammed VI for Science and Health. And in fact, if I can start by summarizing one of our biggest issues in the health sector is the human capital. As you may see in developing countries, but also more and more in developed countries. The problem is not the financing the health system or building hospital or university hospital or primary healthcare center or organizing the universal health coverage. It's mainly the problem of the human resources, the availability, the retention, and the valorization, if I can say, of human resources. And when you see all the results in terms of the health achievement in all those countries, and specifically in Morocco and in Africa, you see that when human resources are insufficient or not well available all around the country, for example, the discrepancy between the urban and rural area, or the discrepancy between the presence in big cities and on contrary on small cities or rural area, or difficult access from some geographic area. You see that the main problem is the availability and the performance of human resources. I will not talk about all the determinants of human resource performance. I'm sure that you discussed about that, and you know all the determinants, of course, the determinant that are related to the training, the competency, the technical competency, the soft skills. But I would like to bring your attention on one very important, unfortunately, I will say it, one of the very important determinants that we see today is the availability of the technology or the platform of technology available in one hospital, one clinic, or one primary healthcare center. And the second aspect is the money value of the acts. Why I would like in our context to talk about the money value? Because sometimes we forget that human resources in the health sector are human. They are not robots. They are not different from the population. They are not different from people working in other sectors. Of course, there are nurse, physician, a biomedical engineer, health administrator, but they are also, and before everything, a member of the society, a member of a population with some specific education, and with specific history, familial history or professional history, etc. And what we saw and what we tried to resolve at the Foundation Mohammed VI for Science and Health is what could be the value of one act or one activity that could help or give the best possibility for this human capital to achieve the objective that we want him to achieve. And I give you one specific example. You cannot give the same value with someone very important that is going to deliver vaccination in a primary healthcare center in a rural area, in Casablanca or in Agadir or in Niamey or in Cotonou or in Abidjan or any city, in comparison with one surgeon or one intensive care specialist in one university hospital in Rabat or in Casablanca or in Abidjan or in Dakar, for example. The value, the money value for the act is not the same. The perception, and this is one of our biggest problems, is how we can convince the health professional to consider the money value or their acts as something very important, and that's something that it can help them to achieve the health objective we want to assign them. And in many theoretical model, and my friend Professor Barghedi knows very well all the theoretical model of human capital or human resources, all the theoretical model that can explain health professional behavior or health professional activities. And all those models are very interesting, but the problem of all this model is that sometimes they're very good, of course, they're very interesting, they give us many interesting scientific and research results. But the problem we have and we see is that the theoretical model, they forget sometimes that these health professionals are human, and we're talking about human resources, that before being resources, they are human. And sometimes there is no rational, there is no logic in their behavior, even if you gave them all the technical aspect or tools they need, or the infrastructure environment they need, and all the titles you may give them. So we have to take into account this, how can I say, these characteristics, because as you may know, the resources are not extensible. I mean by that, the financial resources in all the countries, in all the health policy in our continent, and also in Morocco, are not extensible. And it's very difficult to answer all the needs because of their, how can I say, the history, the training history, but also the environment where they live. So saying that, what are the solutions? How we can build human resource, health human resource capacity to answer our objective or our needs? How we can build this capacity taking into account one health policy in one country, on one region, on one city? How? Is it easy only by giving them a technological platform or tools, or by giving them an amount of money corresponding to their activities? The answer is more complicated than that, my friends. The answer is more complicated. And let me give you some tips, if I may, in order, first of all, to decrease the lack of our needs in terms of human resources. As you may know, if you take only, for example, Morocco, we are in need of 32,000 physicians and in need of 65,000 nurses. But if you take all Africa and all health human resources, we are in need of more than 6 million people. And you cannot train 6 million people in, I'm not talking about short term, but I'm talking in a decades. We need at least 100 years or 150 years if we want to train all those people, not to train those people like we are doing a kitchen receipt or a food receipt, if I can say, because it takes long time to have good human resource in the health sector, long time. For a physician, several years, and for nurses also at least 3 to 5 years. So in order to, if I can say, to have the number needed of human health resources, we need to train them, but not to train them only by having universities or faculties or school of public health or school of nurses, of school of physician, of school of pharmacist, of school of engineer. Not only that, but we need to find a way to have, if I can say, bridges between faculties or institutions that can help us to train health professionals, even if they are not starting in a school of medicine or school of pharmacy or school of biomedical engineer, but starting in a health sciences school or starting in a biology school, etc. We have to find a way to create bridges between schools and faculties in order to reach a minimum of the health human resources that we need. This is the first point I wanted to share with you. The second point, very important, is if we don't have enough human resources at the time we want, and we need, let's say, 100 years or 50 years, 30 years, can we at least decrease the needs or the health needs we have in a population? I mean by that, decrease the number of people sick or decrease the number of disease. It could be very strange for you to listen to my discourse and say how we can decrease the number of disease or the number of sick people. If we cannot increase in a quick time the number of health human resources in order to treat the sick people, so can we inverse our paradigm and think about decreasing the disease or sick people by, my friend, axing our effort on prevention, axing our effort in screening and prevention, primary prevention, of course, and secondary prevention also. This is the second aspect. It may be something very strange, but at the time, or there is a shortage in health human resources, one of the solution, not the only solution, but one of the solution, taking into account that we have to train and train and train more people, one of the solution is to axe our effort to decrease sick people or to decrease the disease by doing primary and secondary prevention. The third aspect that I want to share with you is to find a way to increase the performance or the productivity of people doing the health job actually. I mean by that, physicians, nurses, pharmacists, dentist, surgeon, and all the health professionals, how we can make them do more with the parallel of the money they need to earn, because we don't have to be shamed talking about money, even if we are talking about the public sector or the private sector. We need to take into account the value of one act. Even if you have a salary from the Ministry of Health, or you have some money because you are working on the private sector in order to compensate your activity or your time, this value, this money should be in accordance with the acts you are going to give, either in the public sector or in the private sector. And we have to work more, and I will advise my friend Professor Belghiti and all of you to work on building models, pragmatic models or operational models in terms of implementing research, because this is one of your main interest, is to how to implement research in order to answer some health objective or health policy. And this is something that we have all together to work on, how we can develop a model that takes into account the money value of one health acts in order to let health professionals be satisfied and achieve the objective of the health for all the population, because their objective is to cure people, is to prevent disease, of course, but their objective is not to put in place one health policy. They are working at the micro level, not at the macro level. It is like talking about macroeconomics and microeconomics. We are talking about macro health policy with micro health policy. The micro health policy concerns health human resources on the field, public or private sector. So this continuum between the shortage of human resources, the decrease of sick people, of the incidence of sick people or incidence of disease, and the money value to human health resources are, in my opinion, a continuum over which we have to work together. Because, you know, when you see, and actually we are seeing the, how can I say, the motivation of medical students, the motivation of human health resources all around the countries, we are seeing that is very, very challenging problem, because people, they are changing their mind in terms of health market, if I can say. And let me give you a final example. 20 years ago, when you ask a medical student or medical pharmacist pharmacy student, etc., you ask him, what do you want to do in the future? And they were saying, I want to work in the public sector and I want to be a professor at the university. Today, all they want is to do something that is medical surgical, because the money value is higher. They want to go to the private sector, and they don't want, in the majority, to do a university career. It means that even from the social point of view, there is a change in the paradigm of the way people in the health sector or the health market, they are now thinking. They're thinking more on going to the private sector to be perhaps free or doing whatever they want and earning more money. This aspect we should take into account in implementing new model of research, taking into account all these aspects also in health policy, and in doing our best, not only by saying we have to increase the number of human health resources, not only by decreasing the incidence of disease of sick people, not only on putting a new money value to the medical act or health act, but to think more globally and saying this continuum should be a new paradigm that we should work on, even by creating new theoretical model in order to address something very important for all of us, how we can improve the health of the people, but at the lowest costs possible for all the population, because at the end of the day, my friend, someone has to pay, and who will pay is all of us, because it's the taxes, but also the out of pocket of the people. Thank you so much.
Thank you very much, Professor Heikel, for pinpointing and hallmarking the importance of value for money and incentives on the motivation of health workers as well as students and medical students. And the idea is that we need to combine cost effectiveness in that model of human resources in order to provide more context relevant recommendation for the policymakers on the ground, which is the key issue around implementation research. And this project with Oxford University is around developing implementation case studies. And how can we improve the quality of care through the implementation of sound, context, relevant projects on the ground. So I'm going to share with as well one of my PhD students working and candidates working on the ideas do actually incentives and financial incentive improve the motivation of health workers. He provide evidence from a realist review, a realist synthesis, a scoping review, and then he will provide some evidence from policymakers in Morocco to try to set the landscape, how they think, they perceive whether putting performance-based financing will improve the motivation of Moroccan health workers. So let's hear from Jibreen, and then let's open the discussion afterwards. Thank you, Jibreen. The floor is yours.
Thank you for giving me the floor. I'm so honored to be with you. So when it comes to the motivation of and the performance of the health worker, it is important to note that they are not isolated phenomena. Rather, they are shaped by multiple factors, such as management practices, as you can see here, the contextual, the working condition, and so also we can talk about the broader system level reform. Therefore, instead of looking at motivation and performance in isolation, we position them within a systemic perspective. Next, please. So to further illustrate the complexity of the relationship between the motivation and the performance of the health worker, we reflect, for instance, on the work done by Dimitri and all. This is a causal loop diagramming, highlighting the dynamic interaction between several factors. As you can see here, we have several arrows going in different directions. So in our case, we focus specifically on how performance-based financing may shape the motivation of the health worker. So before we go further, it should be noted that there are a lot of different definitions of motivation, but in our case, we consider motivation, the motivation of the health worker as a complex psychological process that encompasses both extrinsic and autonomous form of the motivation. And when it comes to the performance-based financing, as I mentioned at the beginning, the relationship with the motivation of the health worker is something very complex. So what we mean by performance-based financing before we go further. Next, please. So the performance-based financing is a key policy tool used to improve the motivation of the health worker, and we cannot talk about performance-based financing without talking about the component of the performance-based financing. As you can see here, we have these components such as a government arrangement, we have monitoring, we have financial incentives, and we have also ancillary component. As I mentioned at the beginning, the relationship between the performance-based finance and the motivation of the health worker is something complex. So we to unravel this complexity, we adopt an innovative approach, which is the realist evaluation. Next, please. So the realist evaluation is grounded in scientific realism, therefore has a generative view of causation in this perspective. So causation is not simply about observing pattern, but about unraveling the mechanism that underlies the event that generates outcome. And what we should keep in mind here is that when it comes to realist evaluation, most of the time we focus on mechanism, and mechanism is something hidden. So here we put this slide just to give you a bigger picture about the different cycle when we are doing a realist evaluation. As you can see here, that we move from formulating the research question by building the initial program theory, and at the end, this allows us to formulate some kind of practical recommendation. Next, please. So, and also, when it comes to realist evaluation, we cannot talk about realist evaluation without talking about what we call context, mechanism, outcome. So, as I said before, when we are doing a realist evaluation, we start with building the initial program theory, and the building of this initial program theory is done through what we call the context, mechanism, outcome. And the context mechanism outcome, it is, if I can say so, the articulation of the program theory on how intervention is expected to work, and this is most of the time constructed using this context mechanism outcome. And in our case, as our studio progressed, we found it relevant to extend this context mechanism outcome to what we call ICAMO, which is intervention context mechanism outcome. Please. Next. So when it comes to adopting the different cycle of the realist evaluation, so we start with formulating the research question. It should be noted here that this is a part of a PhD project at the Mohammed University, and the whole question at the beginning was how, why, for whom, and under what contextual condition does performance-based financing shape the motivation of the health worker? And our objective was to elucidate the black box of the relationship between performance-based financing and the motivation of the health worker. As the Moroccan health system is undergoing health financing reform, actually. So our specific objective was to identify the key contextual condition and underlying mechanism through which the performance-based financing, and most of the time the financial incentive, which is one of the components of the performance-based financing in the ongoing health financing reform in Morocco, will shape the motivation of the health worker. So next, please. So after we formulated our research question, so we did the state of the art by conducting a scoping review to understand how different contextual elements may shape the motivation of the health worker. So we did a scoping review, and here I'm not going to give you all of the detail, but I'm just going to summarize what we assume we found from the result of this scoping review. So as you can see here, we put this framework. This is the main finding from this scoping review, and we assume that, for instance, in a healthcare setting characterized by large power distance, health worker may experience delay in resource allocation, and this and they may perceive a lack of support, and may lead to lower their intrinsic motivation and job satisfaction. And when health worker perform in context where this health worker does not belong as part of the community, referring here to the collectivism, the collectivism dimension of the societal culture, particularly in this case in rural areas, health worker may experience rejection from the community they serve, and this may lead them to perceive the low self-efficacy, low self-esteem, and this may reduce their public service motivation. In a resource conference setting where health workers are recognized by the community, this is like the opposite side, particularly in rural area too, this may improve their job satisfaction and intrinsic motivation. So there is also a gender norm. We assume here that gender norm also play a critical role in patriarchal culture, for instance, where female health workers experience discrimination related to the advancement of their career. This may lead to the perception of unfairness, and this can lower their autonomous motivation. Next, please. So we move from the start of the art, as I mentioned at the beginning, when we are doing a realist evaluation. So the first thing after the start of the art is to build the initial program theory. So we built our initial program theory, moving from several cycles, as you can see in this slide, and we already submitted we already submitted this paper, which is under review. Please next. So here when we want to build our initial program theory, so we move from the preliminary research, and this preliminary research help us to identify and to select different candidate theory, as you can see here. So we included the candidate theories such as self-determination theory, self-efficacy theory. We have also agent principle theory. We have crowding theory. We have expectancy theory and equity theory. This theory was included because of their relevance. And when we included this theory, so we base on the core element from this theory to operationalize them as the mechanism in order to build the context mechanism outcome that I mentioned at the beginning. Please, next, please. So here we develop our initial program theory. It should be noted here that the building of the initial program theory. So we built 3 different initial program theory, but here I'm not going to explain the 3 different initial program theory, but I'm going to highlight the last one, which is the initial program theory 3. Please, can you move on? So what we can say here after building the different initial program theory, for the initial program theory 3, we assume that if a PBF program provides non-financial incentives such as medical supplies, training opportunities, and regular supportive feedback aligned with clear performance target in setting where teamwork, recognition, and interpersonal relationship exist, then health worker may perceive a sense of self-efficacy due to their capability to perform effectively and perceive relatedness and expectancy, and this may improve their intrinsic motivation. So here, as you can see in this slide, we put this picture just to give you a little bit some element of what we consider as the mechanism. As you can see in this image, I mentioned at the beginning that the mechanism most of the time they are invisible and they generate outcomes. So we have beneath the iceberg, we have the different mechanism, and we have the contextual element at the middle, and this contextual element trigger mechanism to generate outcome, which is the observable outcome, as you can see at the top of the iceberg, which is here as this is considered as the different contextual element and trick the mechanism, and this improve the intrinsic motivation of the health worker. So we move from building initial program theory as we adopt the realist evaluation cycle. So from building the initial program theory, we refine the different 3 initial program theory through a realist review. Can you go next, please? So we refine the different 3 initial program theory, but here I'm going to highlight on the 3rd one. Please, next. So here we refine the initial program theory 3 by assuming that if a PBF program provides non-financial incentives such as medical supply, infrastructure improvement, and regular supportive supervision aligned with clear performance target in healthcare setting, where teamwork, recognition, and relationship exist along with flexibility in decision-making. Health workers may perceive self-efficacy due to their capability to perform effectively, and they may also perceive relatedness and expectancy, and this may improve their intrinsic motivation. Next, please. So after refining our different initial program theory, we designed the case study. So we designed this case study through by doing some different interviews. So we interact with the stakeholder through interview guide, and this interview guide was informed by the 3 refined initial program theory. So we conducted a semi-structured interview using a guide emphasizing a teacher learner, which is here inspired from Anna Manzano, or positioning to elicit a stakeholder perception, particularly regarding how the different components of the performance-based financing in relation to the Moroccan context may shape the motivation of the health worker. Next, please. So as you can see here that our different participants we have a different type of participant. So we have the participant from the public sector, and you have also the participant from the public sector. So it is much of the time Ministry of Health officials. We have also regional health director and district health officials. So from the private sector, it is financial director, director of affairs, and so on. Next, please. So after we transcribe and code different interview based on the economic configuration from the refined initial program theory. So here, this is the we did the thematic analysis, and here we have some elements such as supervision, transparent managerial practices, financial incentive, which is considered here as the most of the element that we found through the analysis of the different transcription. So after we did the analysis, so we moved from refining initial program theory, we moved to what we call folk program theory. So as I mentioned before at the beginning, we had different three different initial program theory, but I'm going to highlight on the next one, which is the folk program theory 3. The next, please. Yeah. So we assume for the folk program theory 3 that if a PBF program provide infrastructure and medical supply in healthcare setting where verification of metrics is transparent through information system, this may foster the perception of transparency, self-efficacy, equity, goal alignment, and also expectancy, and this may sustain the autonomous motivation of the health worker. So through this evaluation, what we can learn here, the next, please. What we can learn here is that digital information system were identified as mandatory precondition to make verification of performance target transparent, and this may contribute to the perception of equity and expectancy. Leadership also was identified as an important element. Manager supportive supervision, such as coaching, may improve the basic psychological need of relatedness due to the social connection between the health workers and the supervisor or the manager. We can also assume here that effective governance may contribute to the transparency aspect, and the combination of the financial and non-financial incentives such as medical supply may contribute to fulfilling the basic psychological need for self-efficacy and the perception of goal alignment, which was derived from the principal agency theory. So the autonomic aspect is most of the time, it is not at the health worker level, but at the facility level. And the dominant cause is the stagnation of the national reference tarification. This is what this national reference tarification was not updated since 2006. And the stakeholders have highlighted this because according to the ongoing reform, the healthcare setting will be financially autonomous so that the managers or the director of the healthcare setting can use revenues generated from the hospital to purchase the medical supply and also financially incentivize health worker so that they can be more motivated and be performant to deliver high quality of care. So to find out more about our work, you can get in touch through the following emails. So thank you for your attention.